Hi everybody, it's Susan Roberts and today we're talking about drugs for the male reproductive system. I'd like for you to turn to the chapter in your book and take a look at the learning outcomes. We're going to be going back and looking at the hypothalamus, the pituitary. We're going to look at all of the hormones that regulate the reproductive function. We're going to look at pharmacotherapy with androgens. We'll look at anabolic steroids. We'll look at medicines to treat male infertility and erectile dysfunction. We're going to study benign prostatic hypertrophy and the drugs that will alleviate that. And finally, we will use the nursing process to care for patients that are on any of these pharmacotherapies. We're going to start with the background of the male reproductive system, and this should be a review from your anatomy and physiology courses. And there isn't much in your book about this, but we'll go ahead and kind of do a review. So we have the external and internal sexual organs. The external is the penis and scrotum, and the internal are your testes, seminiferous tubules, the epididymis, vas deferens, and seminal vesicles, the ejaculatory glands, spermatic cords, the prostate gland, Cowper's glands, and the urethra. So if you're taking a look at this chart here, this graphics, you'll see all the different organs that are involved, and down below you see specifically within the testes the epididymis, a little coiled structure residing on the top of the scrotum and testes, and it's made up of little coils, and they are the seminiferous tubules, and this is where maturation of the sperm cells takes place. So now let's take a moment to pause, maybe pause this slide, and then study the location of the male sexual organs before we move on to the functions. So now we want to test ourselves on the functions of these organs. So we're going to look at the testes, seminiferous tubules, etc. So what have we got here? So your testes produce the sperm and testosterone. Okay, your seminiferous tubules are where the sperm mature. And then your epididymis collects sperm from the testes, and the vas deferens is a muscular tube that transports the sperm from the epididymis in the testicles up to the ejaculatory duct. And then the seminal vesicles join with the vas deferens to form the ejaculatory ducts, and then those travel through the prostate gland. Your ejaculatory glands combine with the sperm stored in the ampulla and with seminal fluid, and then they transport them to the prostate, and that is formed by the vas deferens. The spermatic cords are formed by the vas deferens. Your prostate is a gland that releases prostate fluid, and the Cowper's glands are beneath the prostate, and they add fluids to the semen. And finally, the urethra is used for transport of semen and for urination. So if you got all those correct, then you're doing really well. So in men as in women, reproductive function is regulated by our pituitary hormones and the gonads. In fact, the hormones are the same in men as they are in women. However, in men, the hormones secretion is more constant through the month, and so treatment is less complex. But we still have our gonadotropin releasing hormone, comes from the hypothalamus. Our follicle stimulating hormone makes the sperm, and the luteinizing hormone makes the testosterone. So very similar to those in the female, where the egg is produced and then ovulation occurs under the direction of FSH and LH. So here on the right we see that we have a negative feedback loop. And so think about that in terms of, your own heater at home. If your room was 63 degrees and you wanted to warm it to 72, you would turn the heater on. You would set the set point to 72. The heat would come out, and as soon as the levels rose and got to the level of 72, the heater would shut off. So the same thing happens with this. So you can see the LH and FSH cause the testosterone secretion, stimulates the sperm development, and when those blood levels are high, then that's been achieved, and then there's a negative feedback exerted on the hypothalamus and the pituitary, and the whole thing shuts down. That would then decrease the levels in the blood, and the whole thing would start again. So what are the major male reproductive processes? Well, we have spermatogenesis, that's making the sperm, and then the regulation of male sexual functioning, so sexual intercourse. And the symptoms or manifestations that you might see if there were problems in any of these areas are usually going to be pain and urinary retention and maybe erectile dysfunction. Now, what are the androgens and anabolic steroids? So testosterone is an androgen, and it's responsible for maturation of the male sex organs and secondary sex characteristics, such as body hair, muscle mass, the increased size in the larynx or voice box that happens during puberty. And testosterone starts during puberty and declines in later adulthood. Testosterone even increases erythropoietin, which makes more red blood cells, which equals a higher hematocrit and hemoglobin in the male. So men can enjoy a little bit more oxygen transport because their red blood cells H and H are higher. So the main things will be, so you're looking at growth and health and maintenance, maturation of the sex organs and secondary characteristics. It's responsible for men's libido, their erectile function, their body muscle mass, their strength, also their bone mineral density. We think of osteoporosis in women, but men also need to have dense bones for strength. And they are not as at risk for osteoporosis as women are because women's estrogen, as they go through menopause, decreases and stops driving the calcium into the bones. But men don't seem to have quite that problem, although they can get osteoporosis. The other thing that testosterone does is it helps men with their energy level and a sense of well-being, a sense of feeling good. And the androgens and these anabolic steroids are made in the testes and in our adrenal cortex, the adrenal glands, of course, that sit on top of the kidneys. We have a control over the hormone production, and again, this is that negative feedback loop, so I don't think I need to go into too much detail on this, but the hormone gonadotropic releasing, working on FSH and LH. The FSH stimulates the seminiferous tubules, and those are what produce the sperm, and the LH stimulates interstitial cells that produce the androgens, and androgens are sort of a precursor to testosterone. Okay, and then as those levels start to rise, they exert that negative feedback on the rest of the hormones. There are a number of medical problems that can arise for men. One starts in development. There's a condition called cryptorchidism, and that is failure of the testes, one or both, to descend into the scrotum. And we need testosterone and HCG for that. So there's one problem. Another would be delayed puberty, maybe a deficiency of the hormones. And then another would be basically endocrine disorders. And that would be from a condition from called hypogonadism, menotropins, and you could also have hypothyroidism. If your thyroid's not working, then you're going to have deficiencies in reproductive areas. Somebody could go on thyroid meds for that. And another would be, this is an endocrine disorder, Addison's disease, and that's, remember, where they have a insufficiency of cortisol, the stress hormone, and aldosterone. So those are some medical problems that men can experience. So lack of sufficient testosterone secretion by the testes will result in hypogonadism. So there's primary and secondary. Primary is usually caused by a case of the mumps, maybe a trauma, some kind of inflammation, whereas your secondary is caused by a lack of the hormones, FSH and LH. And also we know things like Cushing's syndrome and thyroid tumors and certain medications can cause the secondary type. So you have primary hypogonadism, failure of the testicles and penis to grow and enlarge. And so there's a condition called micropenis. Men end up with low libido, low sperm count, reduced muscle mass, small testicles, sparse facial hair, sparse axillary and pubic hair. And so it's all the things that are supposed to be happening during pubertal growth, and it's all delayed. Now, you wonder, is this going to last for the rest of their life? And the answer is no, because they can take androgens and treat this condition and achieve their, going through pubertal developmental changes. Okay, so other kinds of things that might impact need for androgen treatment would be autosomal clotting disorders. There's this angioneurotic edema and tissue wasting and advanced breast cancer or endometriosis. So those can impact androgen as well. This is a picture of the hypogonadism. So you can see the very small penis size, and you can see the angioedema there around the lips and face. So those are some real things. One of the things that you can do is look in your book under Farm Facts. I always like to look at that. They talk about ED, for example, erectile dysfunction, 18 million men over the age of 65 experiencing that. Smoking causing ED, 60% of smokers will have that. And men with diabetes, 50% will have ED. And benign prostatic hypertrophy. At age 65, about half of men will have BPH, and at 85, about 90% of men. And then as far as infertility in males, it runs about 12%. What are some drugs associated with the secondary type of hypogonadism? So there's a list here, and you should be pretty familiar with most of these drugs because we pretty much talked about all of them all semester long. So ketoconazole and antifungal. Remember the azole drugs, the antifungal drugs. And your glucocorticoids that cause Cushing's syndrome. Those are given for inflammatory diseases like rheumatoid arthritis and really severe respiratory diseases. Remember spironolactone interferes with adrenal cortex aldosterone, and cimetidine, an H2 blocker for GERD, and phenytoin, Dilantin, anti-seizure drug, any of your opioids, alcohol, and the anabolic steroids. So you would think it's kind of counterintuitive that your anabolic steroids would cause a problem of hypogonadism. And so we're going to talk about that because it all has to do with the dosing. So a little bit is going to help the hypogonadism, and too much is going to be a big problem. We'll talk about our androgens. Okay, so you can look in your book on the table that lists your selected androgens and anabolic steroids. And I like these tables. They give the drug and the dosing and the adverse effects. And always the italicized are just common effects you'd see, and the underlined are more serious, that are more rare, but you can see them and you should be aware of them as a nurse. So you've got your natural androgens, testosterone cypionate, enthanate, propionate, and then you have synthetic or man-made, which are your danazol, danacrine, fluoxymesterone, halotestin, and methyltestosterone, the androids, Orotin, and Virolon. There's others. One is nandrolone, and the other is oxandrolone. And so when you see the ONE, you know, of course, that that is testosterone. Let's talk a little bit about androgen therapy. So remember what it's designed to do. It's supposed to restore libido and help with erectile dysfunction. It's supposed to decrease depression, increase masculinization. And these drugs usually work within days or weeks. Men will start to feel some response to these drugs within just a few days. So your testosterone base, or andro, is the prototype drug, and so that's used for the hypogonadism in males, and also to help with some virilization or depression or things like that. And so men can have their blood drawn and they can find out exactly what their testosterone levels are, and they're only going to need replacement if their levels are really low. So, so the effects would be the male sex characteristics starting to reappear if they've been missing. And you will have the adverse effects from the larger doses. Okay, it affects your aldosterone, so you start to retain sodium in water. You can get edema, liver damage, other side effects, acne and skin irritation. We'll talk about those. So always take time to review your nursing considerations and patient teaching. And it's good to go through those, because this kind of gets to the heart of what are we as nurses supposed to be teaching our patients. Okay, so also look at how these meds come. So androgens, or testosterone, comes in a variety of different things. You can get a patch, you can take a gel, a nasal spray, buccally, you can get IM, little implantable pellets. So there's all kinds of ways. And I never usually have you memorize the milligrams. It's just too much to have to do. Now, what are some effects of increased testosterone in women? Did you know that women actually have testosterone in their systems? Well, we do, but we have it in very small amounts. But it is good for our libido. So hold this thought, and we're going to get back to it in another minute or two. Androgen replacement problems can occur. So what we've talked about are, the low dosing versus high dosing. So your high dose effects, men can get GI problems, liver dysfunction, so they should have their liver labs drawn. It can cause insomnia, and now it can swing back to sexual dysfunction. So instead of helping that libido, now it's causing low sperm count and impotence. So in really high doses, it can cause oligospermia, okay, low sperm count. And it can cause priapism, which we know, you've all seen those ads when men take Viagra. It's erection lasting 4 hours or longer. And so that can be a problem, because the blood that's filled the penis can cause constriction. So it can be a serious problem, and it needs to be treated, and we'll talk about that. The picture you see here is gynecomastia, okay, or I like to refer to them in the scientific term, moobs, or man boobs. Okay, so no men want these. They try and avoid that. Another condition or adverse effect is acne that can occur. High cholesterol, men stop metabolizing their cholesterol. The water retention, and testicular atrophy can occur. So those are some pretty serious things. The people that should not take androgen replacement are any male that's had breast cancer or prostate cancer, renal disease, cardiac problems, liver dysfunction, high levels of calcium, and benign prostatic hypertrophy or hyperplasia, which is BPH, and high blood pressure. Men should not take these drugs if they've had these conditions. Make sure that you look at your nursing considerations. You're going to look at your prototype drug, and the things that you want to be concerned with are located here. Some we've really already talked about. There is a black box warning for these nursing considerations, and that is virilizing in women and children. It is pregnancy category X. Okay, so men will get impaired sexual functioning, diminished libido, the hair will disappear on their body, and small testes, etc. And so I think we've kind of talked enough about these. And so in women, at the bottom you see of this slide, here's what happens if women take testosterone and get in too high levels. Deepening of the voice, because it affects the larynx. Facial hair growth, which they start to have facial male hair patterns. They can even get a little baldness. Enlarged clitoris, and irregular menses. So it can affect women in negative ways as well. So women have to be careful. If women have gone on hormone replacement therapy, especially if they go to the compounding pharmacy and have the pharmacist make up, due to their labs, the estrogen, progesterone, DHE, and the testosterone, then if they get too much of the testosterone, then it can cause this. But a little bit to replenish what they're lacking is helpful for women that are older for their libido. Now look at these pictures of anabolic steroids. They look positively fake. It's men who have been taking these testosterone derivatives, and they get the anabolic effects. So anabolic means tissue building or muscle building. And so what they have, these perceived ideas of what they're going to get out of this. They think, oh, I'm going to have this great performance, and of course, you know, the weightlifting, and people in sports have taken these for running and being stronger, etc. And Lance Armstrong was caught using these kinds of steroids, as well as stopping along the routes of his bicycle paths and going into his trailer and getting blood transfusions, getting that extra red blood cells, the H and H, to carry more oxygen. So there's a number of ways to cheat, and but anabolic steroids are still being used. But the perceived benefits would be enhanced sexual performance as well as the aerobic performance, and this turns out to not be true. So we'll talk about that. Now this is showing you some of the serious long-term effects with the anabolic steroids. And so in the beige boxes, those are problems with men, and in the white boxes, it's problems in men and women. So just in men, headaches, baldness, man boobs, enlarged prostate, shrinkage of testicles, everything you would want in the opposite, right? And reduced sperm count. Okay, and then anyone can get strokes, blood clots, high blood pressure, nausea, bloating, impotence, aching joints, aggression, they call it the roid rage, tendon injuries, it affects the tendons, urinary and bowel problems, mood swings, liver damage, and acne. So you can see this picture of this severe acne, just looks awful. Okay, and so women get the male secondary sex characteristics as well. So these are not to be fooled around with, right? So now we're going to talk a little bit about male infertility. Okay, so men that have less than 20 million sperm per milliliter in their ejaculate are considered to have oligospermia. Okay, azoospermia would be possibly from a blockage of the vas deferens, wanting to carry it out through the ducts, that they might have azoospermia if those ducts are blocked. And so 30 to 40% of infertility problems are caused by the male's reproductive system. So usually we think about it as females, but it can be the males, and it's usually something to do with the sperm. The problem is it's not very easy to treat pharmacologically. And they say that only 5% is caused by an endocrine problem, which, like the Addisons and things, we could treat. So if you do treat it, they say it's expensive and it requires a lot of injections. Okay, so sometimes with problems with male infertility, they'll go right to in vitro fertilization or the IUI, which is intrauterine insemination. And I don't go into that really in female reproduction, because it's just a whole highly complex and specialized area of medicine. But the IUI, basically what they do is they take the men's sperm and wash it, and then they inject it in the female after giving her some hormones to help the lining of the uterus be really receptive and things like that. And then the sperm still has to travel up and fertilize the egg up in the fallopian tube. It's only about 20% effective. Now, in vitro fertilization's more complex. They have to give the woman a lot of hormones to ripen those eggs. Then they will harvest some of the eggs, and they fertilize each egg with a sperm, and then they grow it, and when it's a few cells, it's a little blastocyst, they implant it in the female. And so there's a lot of office visits, lots and lots of doctor visits. So that's one of the downsides. It's also very expensive, and none of our insurance plans these days covers it. So you can look at in vitro fertilization being probably like $20,000 to $25,000. So it's quite expensive. Okay, so meds for male infertility can include HCG, human chorionic gonadotropin. That's what's released from the fetus when it's first implanted. That'll help the testosterone and sperm. There's another drug, pergonal, menotropin, and that mixes the FSH and LH to help the hypogonadism. Testosterone for those exhibiting hypogonadism. And then anti-estrogens. So if men have too much estrogen in their system, and they do have small amounts, tamoxifen, you've probably heard of that, which is a kind of an anti-cancer drug, and clomiphene. So that will block estrogen if they're getting too much of that. So that will really help. And we're going to talk now about sexual response. Okay, so that requires some coordinated events. One is for erection and the other is for ejaculation. So the erection is needed to be controlled by the parasympathetic nervous system, and the ejaculation is controlled by the sympathetic nervous system. So remember what we talked about, parasympathetic, feed and breed. So you got to be all relaxed, you got to be in the mood, in the zone, just like women do. Okay, so the afferent nerves send messages to the brain, and either physical or psychological stimulation, and then the efferent nerves come down from the brain via the parasympathetic to the penis. And also men can have spinal cord reflex erections. So men that have had a spinal cord injury can also get erections, but it's not always as strong or as frequent. So sometimes they need some help, and they can take the ED meds that we'll be talking about. Now, looking at this graph, this is the same picture that we saw. You know all the different parts, your testes, scrotum, the epididymis, and where the sperm travel up through the vas deferens, across the bladder, and then down into the urethra through the prostate, gets introduced with fluid by the seminal vesicles, bulbourethral glands, and then down through the urethra and out the penis. So if you think of the little word Steve, it's seminiferous tubules, then epididymis, then vas deferens, then ejaculatory duct. And what is sexual dysfunction caused by? Well, it can be caused by a lot of things, and it's considered impotence. The old-fashioned word used to be impotence, and now we're calling it sexual dysfunction. Impotence kind of has a meaning to people that you never could get an erection or have sex, but it's not really that way. So it could be just inhibited desire from lack of testosterone. It could be true erectile dysfunction, or ED we call it. It could be ejaculatory dysfunction. We know there are a lot of drugs that cause that. All those anti-anxieties, your psychotropic drugs, antipsychotics cause like delayed ejaculation or ED. And then failure of detumescence. So what is that? You've all heard about that. Erections lasting 4 hours or longer. Okay, and so that's a big problem because, as you can see by this picture, the corpus cavernosum of the penis fills with blood during an erection and causes the erection or the firmness of the erection. Okay, so what happens is during failure of detumescence, meaning you can't get rid of the erection, then you have to, it can cause damage to the penis. So you have to, these men end up going into the ED with their ED problem, and you guessed it, they have to evacuate the blood because they're going to get constricted and they're going to have penile necrosis. And I don't know any man that wants to experience that. So yes, I know you're all getting the chills out there, but what they have to do, they get a big syringe and needle and they have to go in and withdraw the blood. So that's a big problem and probably kind of embarrassing as well. So here's what's happening. The parasympathetic nervous system stimulates this CGMP, and then the penis smooth muscle becomes relaxed and it's allowed to fill with blood, and then an erection occurs. So you have phosphodiesterase in your system, and what that does is it degrades the CGMP. And so then what we have to have happen is now you can't have the smooth muscle relaxation and blood filling, so you don't get an erection. So in ED, you take a phosphodiesterase inhibitor, and then that allows for the relaxation of the muscle and the blood flow, and it allows a sustained erection. So some men, as they get older, typically over 45, 50 years old, they can get an erection, but sometimes it doesn't last through the sexual intercourse, or they just have a problem achieving an erection. So we'll talk about some of the drugs for that. And so anybody know what CGMP is? Well, if you took your chemistry course, you'd know that it's cyclic guanosine monophosphate, and it's sort of a chemical messenger. So what are conditions that cause sexual dysfunction? Well, these would be things like decreased libido. You can have meds like beta blockers, your antidepressants, people that are diabetic, those kinds of things. So certainly advanced age and any of the cardiovascular diseases, anything that affects the blood flow. Okay, so stroke and high cholesterol. Your diabetes, your patients end up over the years having poor vascular response, and they actually have micro and macrovascular damage. So one of the areas it affects is erection. So it's really important for them to control their diabetes when they're young, so they won't have this happen as they get older. There's other diseases, MS, Parkinson's, spinal cord injury, any kind of trauma or penile injury. What happens with smoking? 50 to 60% of smokers will have ED. So guys out there, do not smoke. And girls out there, tell your guys not to smoke, because you don't want them to have ED either. Okay, then what about psychogenic causes? So guilt or fear of failure, depression, those kinds of things can also cause sexual dysfunction. So the drugs that cause sexual dysfunction are, look at all these lists. I don't expect you to memorize these, but you should totally be aware of them because you're giving all these to all these patients, right? So anticholinergics, remember the can't see, can't pee, can't spit, can't shit. Well, it also causes abnormal sexual functioning, decreased libido. Okay, your antidepressants, mostly the SSRIs, your antihistamines, antihypertensives, thiazide drugs, beta blockers, antipsychotics, any of the sedatives, any of the social drugs like alcohol, the opiates, marijuana, cocaine, and then chemotherapy, digoxin, some of your H2 blockers like Zantac. The interesting thing is those are for GERD, but the PPIs don't seem to have sexual dysfunction as a side effect. Okay, so remember also that if you're taking an ED med, they're phosphodiesterase inhibitors, and your nitrate drugs for chest pain cause some of this vasodilation that the phosphodiesterase inhibitors do. So remember to tell your patients you cannot take them together at the same time, because if you get too much vasodilation, you know what's going to happen. You're going to have some fainting and loss of blood pressure. So a little bit of low blood pressure in somebody from one of the drugs like taking Viagra is not a big deal, but taken together with a nitrate can put you in the ER. Okay, so what is the pharmacotherapy for ED? It's a picture of Cialis there. It's all the fills, sildenafil, vardenafil, and tadalafil. Okay, Viagra, Levitra, and Cialis. So think of the fill, F-I-L, filling the penis with blood. Sorry, that's my only way to help you guys remember it. Okay, so these are the phosphodiesterase 5 inhibitors. Remember, they don't cause an erection. They're not an aphrodisiac. They're not a Spanish fly. Okay, they just enhance the erection that you already get from physical or psychological stimuli. Okay, so they'll last like 20 to 60 minutes, or sorry, the onset is like 20, 30 to 60 minutes, and they'll last 4 hours. There is a longer Cialis that lasts 24 to 36 hours, and now I know there's a daily Cialis, and they said it actually helps BPH. So anyway, that's how they work. So remember to tell your patients about the organic nitrates. Also look at liver dysfunction. Your phosphodiesterase 5 inhibitors, prototype drug is sildenafil, Viagra. We've talked about what it does, allows the blood flow, blocks the enzyme phosphodiesterase 5, and so that you get the blood flow and relaxation. And there are some side effects, and those are usually, it's a vasodilator, so think about that. Men get headaches, they get like red eyes, like they call it the Viagra hangover, a little bit of flushing, dizziness, maybe even a rash. Sometimes they can have visual changes, so that's really serious. The priapism, the erection lasting 4 hours, those are very serious things. Okay, and men are only to take 1 pill daily and not taken with the nitrates. So they shouldn't take a pill in the morning like with their wives and then take another pill that night with their girlfriend or something. Okay, so make sure that you talk to them about that. Now we'll talk about BPH and what to do about that. So you see here this picture shows the normal prostate and then the enlarged prostate, and what it does, it impinges on the urethra and leads to decreased flow of urine and a sense of urgency and frequency in men. So now you hear about the men 50 and over getting up in the night to go to the bathroom when they never used to have to, and it's not because their bladder's way more full of urine, it's just they get this urgency and frequency thing. And if they don't treat it, they can get UTIs, they can get kidney infections, and in really serious cases they can get retrograde urine and hydronephrosis. Okay, so a lot of times they'll have incomplete emptying of the bladder. And so what we do, we could put them on meds, but we also tell them to avoid drugs that will cause urinary retention. Okay, and so that's your anticholinergics, antihistamines, decongestants, alpha-adrenergic agonists, and testosterone can do that. Also at bedtime, cut down on the fluids, cut down on the alcohol, cut down on caffeine during the day. Okay, and so typically they don't do surgery until it's really an advanced situation. They'll always try drugs first because they really want to not have to go in and do surgery. So there's a pathogenesis of BPH, and it's either static factors or dynamic factors. And the static is just that the gland itself grows 2 to 3 times its size as men age, and it blocks urine outflow at the neck of the bladder. The dynamic factors are the alpha-1 receptors at the neck of the bladder. And do you remember what kind of muscle the bladder is made of? Well, it's made of smooth muscle. So you'd have to go back to, remember the alpha-1s, the receptors in your body and what they do. A, boy has kicking legs. So A for arterioles. Typically you see the constriction of the blood vessels. Okay, so when these alpha-1 receptors are activated, they compress the urethra and they increase resistance to urine outflow, and they constrict the blood vessels. So what's the worst thing about BPH? Okay, so do you need catheterization? Maybe men need to visit the restroom more frequently. Would it be men fall in the night getting up? Would it be hydronephrosis from urinary retention? Or might it be all the above? And the answer is all of the above. Okay, so I have known patients that have gone out partying in the night and they drank too much alcohol and it activated their alpha-1s and caused acute urinary retention, meaning they could not void. So in order to deal with this, they have to go into the ER and get catheterized. It's very, very painful. Think of, anytime you've been out somewhere where you have to go to the bathroom really bad. And so what do you say? It's like, oh, I'm dying, I have to pee, it hurts. So anyway, this is a very serious situation. I tell my patients, if you were on a desert island, you would die from this because nobody'd be there to catheterize you. So you got to watch the caffeine, you got to watch the alcohol intake as well. So pharmacotherapy would be your alpha-1 adrenergic blockers because they're the ones that are stimulated that cause the problem. So what these do, this would be Flomax. They will relax the smooth muscle in the prostate and the neck of the bladder and the urethra. You have doxazosin Cardura, terazosin Hytrin, and tamulosin Flomax. So if a man has BPH and high blood pressure, the best thing for them to take is Cardura or Hytrin, and that'll help control their hypertension. If they don't have the high blood pressure, they can just take Flomax, and all that does is help that neck of the bladder to relax. And they can just get, because it's a vasodilator, they'll get a little dizziness and hypotension. They should get up slowly. Okay, so what are the effects from alcohol? They are increased alpha-1 adrenergic receptors, and they are stimulated and they will cause blockage of the urine. And we also have 5 alpha reductase inhibitors, and those offer a different alternative. Okay, so that's finasteride or Proscar. The problem with those is they'll take a little bit longer to work. The Flomax will just take like a few days, a couple weeks to take its effect. With the Proscar, what that does is it actually shrinks the prostate. So it blocks testosterone in order for that testosterone not to enlarge the prostate anymore. So it does have some bad side effects, though, that the Flomax doesn't really have. Decreased libido and erectile dysfunction. So if you look in your book on your tables, you'll see some of these side effects, okay? And so you're going to want to know what those are. The common side effects as well as the adverse effects, okay? So another thing with some of those, the Flomax, the vasodilators, nasal congestion and the facial flushing, I think we talked about that, sometimes vision abnormalities, and then the real serious is that hypotension, okay? And I've even heard of optic neuropathy, kind of a ischemia that happens and can cause blindness. So that's pretty serious. So tell your men to get in there right away if they have any visual problems. Your prototype drug, finasteride or Proscar, we just said what it does. It shrinks the prostate, and it can really cause some sexual dysfunction. The main thing to remember is it is teratogenic to the male fetus. And so this is very, very important. Women should not get near this drug if they're thinking of getting pregnant. If they are pregnant, they shouldn't touch it or even be near it. And men should go off the drug if they're going to try and get their female partner pregnant. Okay, so that's really, really important to mention. Now, why is this picture here of this man with his hair? Well, they started out with Proscar as the drug for the BPH, and they found out, wow, my hair's growing back. So now they can sell it as the same drugs they would give as Propecia. So it's a drug that you can take if you are suffering from male pattern hair loss. Now, the effects of pharmacotherapy you want to know about. So they can also get urinary retention, nocturia, dribbling frequency. So those are some of the bad side effects. The hypotension, there's a thing called first dose phenomenon, and that it can happen like the first time they ever get it. Be with them the first time they get up. In fact, I always give them the call bell and go, would you just call me and I'll come in and help you get up because I don't want you to fall. Your alpha blockers should be cautiously used in clients that have asthma or heart failure. They can cause the bradycardia, bronchoconstriction, and they take months to take effect, and they can impact impotence and volume of ejaculate and decrease libido. So our patients just need to know about these things. So the final thing we're going to do is match the following. So see if you can figure out which one shrinks the prostate. Viagra, Flomax, Hytrin, Proscar, or testosterone. Okay, and the answer is your Proscar. And which one, B, relaxes the bladder and prostate? Viagra, Flomax, Hytrin, Proscar, testosterone, and the answer is Flomax. And C, which blocks phosphodiesterase to enhance an erection? And that is A, Viagra, or Cialis, or Levitra. And then D, what causes prostate enlargement? And that is testosterone, E. And then finally E, what is good for men who have hypertension and BPH? And that answer would be Hytrin. So you've done real well. I know it's a lot of information, but some of these things will be on the exam, and I know if you'll study your book, look at those prototype drugs, and study the nursing considerations, you'll be on the way to being an expert in drugs for disorders of the male reproductive system. Thanks and have a great day.